Good afternoon, everybody, and welcome to this webinar through COVID-19, COVAX and beyond. And here we are with Kim, Poyner and Riwka Hagen for our third conversation and coaching session around COVID-19, a Q&A session. My name is Linda Govan. I'm a Senior Manager at the West Vic PHN. I'm based in the Ballarat office. And I firstly would like to start with an acknowledgement to country. I would like to acknowledge and pay my respects to the traditional owners of the land in which we meet today. I'm speaking to you from Wadawurrung country, and I would also like to acknowledge all Aboriginal and Torres Strait Islander peoples who may be present with us today. So for this session, as I said, we have Riwka Hagen from Medical Business Services and Kim Poyner from MediCoach. And I'd like to welcome everybody who is connecting in today for participating in the session. And I'd also like to welcome the West Vic Practice Facilitation team. If you're online there, I'm sure you are. And also just throw out a welcome to Anne O'Callaghan and Sarah Hall, who are new to our team and are now have the responsibility of fronting our practice facilitation help desk. And you can contact them via our QI inbox. So today's session is interactive and we'll be responding to your questions as we go along. But for now, I'll just hand over to Riwka and Kim. Welcome.
Thanks. I'm happy to kick this off too. Lovely to have you as part of the panel discussion today, Lynn, as well. And always great to catch up with my buddy Kim for some more COVAX and COVID conversations. This is the second time that we've kind of approach this topic for West Vic PHN. I really want to encourage everyone who is participating today to please submit your questions in the Q&A box of this Zoom webinar, and we will certainly be focusing on your questions first and foremost. And so, yeah, we really would like to get your participation to kick off today's session. So, Kim, do you want to say a few words of introduction before we get started?
Sure thing. Hi, everyone. Thanks for coming today. I'm up in the floodplains up in New South Wales at the moment. So if my internet is a little bit problematic across the course of the session, my apologies right from the get-go. We can't control the weather up here, unfortunately, at the moment. It's quite turbulent, as you can imagine. So my name's Kim Poyner from MediCoach. My background is as a registered nurse, practice nurse for some years now, and a nurse immuniser. I've been helping with the 1A rollout, as well as doing some strategy planning for COVID throughout the nation as well. So, Riwka.
Yeah, wonderful. Thank you for that. Yeah. Thanks for all that. And I've just brought Katrina Martin from West Vic PHN into the conversation as well. She will have some information to share. Katrina, if you're there now, feel free to turn on your camera and just come and say hello as well.
Hi, everyone. Yes, sorry, I don't think I can start my video. It's having a bit of an issue, but yes, I'm Katrina Martin from West Vic PHN. I'm the Workforce Development Program Lead. So
okay.
Jump in at any stage. Thanks.
I've just promoted you, Katrina, to a co-host as well. You should have better success now with your video there. So it's this is just that technology.
There we go. Oh, I've got my got an old. I'll try a different background.
It's all fine. You're here now, so that's terrific. Good to have you along. So Kim, I thought what we might start off with is just some of the questions that came through the registration of the participants today. And again, for anyone who's here today, feel free to pop any new questions that have come along into the Q&A box, and we'll keep a really close eye on that. So one of the first questions that came through, Kim, was with regard to the use of medical students in administering COVID vaccinations. Are there any rules and regulations around that, and what is your expert advice in that space?
Thanks so much, Riv. So, of course, everyone needs to do mandatory training. We need to go in and do the COVID mandatory training before anyone can immunise. And I actually found a really beautiful resource, because I know that a lot of people have been having questions around particularly the big AZ, so AstraZeneca, what does immediately mean in terms of drawing up. And I found a resource from the department health. So what I'm going to do is I'm going to pop that in the chat box right now, and on there's a beautiful table that actually outlines the roles and responsibilities of each workforce team member and what their capacity is, as in their scope of practice is in delivery. And of course, it's having a GP on site. So yes, absolutely. If they've got that within their scope of practice, they've done that as part of their training as a medical student, well, absolutely go for it. Use them as workforce while we can, and obviously have a GP on site that can, obviously be that supervisor. So I'm just going to put that resource in there now so people can have a look at that.
Oh, thanks for that. And look, while we continue working through that, Kim, that's just gone to the panelists. So maybe just reselect that for all participants so that that they can see that as well. Fabulous. So that's good news. So yes, use those medical students. And of course, there isn't a greater way that they can get some real practical experience in this space as well. And, it is really all around that scope of practice, isn't it? That ensuring that they have done the training and they're good to go and that they're comfortable and confident. I mean, if your medical students are saying, look, I'd prefer to be watching for a little while longer, you wouldn't want to be saying that, oh, no, you're it now. So just manage that, I guess, on a case-to-case basis.
That same resource.
Another really interesting.
That resource also has on, I think it's page 70. Let me have a look. 79. It has some really great screenshots of what to do in terms of the process, in terms of drawing up AstraZeneca. So I would recommend people go in. You could even screenshot that, laminate that and put it up on the wall just for additional sort of support for people as well to make sure that they're handling, because of course, contamination risk and wastage is the two big considerations here.
A question's just come through, Kim, as well, just with regard to nursing students. Would they be considered any differently to medical students?
Well, again, what year are they out in? Have they done their immunisations? Have they got their qualification for, intramuscular injections? That would be the things that I would be looking for. And have they got adequate supervision? And again, in that same resource, which is why I'm so stoked that I found it, it also has what's deemed appropriate supervision. All right. So they talk about, for each staff member, how many supervisors would you require? So I would have someone buddying up. You could utilise them as a first aid officer, if you like, until they've watched a few being administered. They can certainly be doing some double checking.
And of course, I think for any practices who might be still a little bit unsure, it would be really wise to maybe flag this past your medical defence organisation, Avant or MIPS. And, perhaps, speak to APNA as well, as especially as far as nursing students are concerned. I'm not sure if APNA have come out with a position statement around the use of nurses for this as well. So sort of seek some broader feedback as well, and give yourself and your organisation the assurance that, that all is okay and above board. So there is a comment that's come through too, or a question from Angela saying, second year deacon nursing students under the guidance of an RN, looks like that's sort of been okay, that, they're happy to go. So I would imagine that would then follow through for any other learning institutions as well.
And I guess we've got to also be mindful, although we are in a teaching environment, this is really new for a lot of people and new for the practices. So, obviously settling into the delivery is going to be the most important thing, isn't it? And making sure that we've got the systems in place and practices that are receiving just smaller doses than what they anticipated. This gives them that opportunity to have that QI approach. Have we got everything in place? And can we have some teaching time for students, ones that are really, going to be struggling to get all the doses throughout the day? Maybe it's more they're just watching and monitoring what you're doing rather than actually being actively involved. So again, just thinking about what your capability and capacity is without, stressing further workforce out at this stage.
Yep, sounds like sage advice. Any other feedback from our PHN reps? Linda?
I was just going to say, for those looking at the document, just have a look at page 12. It does talk about what the authorisation requirements are for the workforce. It might just help explain that in a bit more detail. Thanks.
Great resource, isn't it?
Fantastic. And hey, listen, we had another really hairy question come through that, Kim and I got a little bit excited about when we saw this as well, which is around how practices might deal with any staff members, but particularly nurses who are not keen on receiving the COVID vaccination themselves. That's a bit of an ethical dilemma and quite a difficult situation. What are the sorts of thinking points that you think are really pertinent in this space, Kim?
Well, I think that, we obviously want to make sure that there's informed consent and people are across what's going on in terms of the vaccines. I know there's been a little bit of a scare with, the Pfizer out in aged care facilities of late. And also there's been the blood clots from overseas. So just ensuring that they have the adequate advisement and knowledge at hand to make an informed decision. That's what informed consent's all about, isn't it? And giving them, it's not mandatory, giving them the opportunity to go away and think about it. Of course, the 5th edition accreditation standards, this is your space, Riff, talks about an ethical dilemma. And this would be a great ethical dilemma to write up, particularly one of the 1B practices that I was working with the other day. They actually had one of their reception staff say that she doesn't want to actually have it, and what's their position on it. So again, what alternate roles maybe can you provide this person? But it is, again, going to come down to the practice itself, isn't it?
Yeah, I think this is an interesting space as well. You're right. I'll talk a little bit more about how you can use these kinds of examples as far as that evidence required for the ethical dilemma situation as far as accreditation is concerned. But I think a one-size-fits-all type of response is just not appropriate in this space. So there may be practices where if there are no other sort of relevant circumstances, then, quite rightly, you can't force staff to undertake this. And really the practice needs to undertake its own risk assessment in terms of what does it mean for your practice if a staff member or a number of staff members refuse to be vaccinated. So it may be that the risks associated with that are quite low. And I would imagine that would actually be the majority of practices where practically the risk of someone choosing to not vaccinate are really not that high. And, I think practices need to be careful that they don't sort of overstep that remit of expecting all staff to be on board with this. And so if particular risks aren't identified, I think you kind of need to allow people to make up their own mind about it. However, there might be circumstances where your practice is in a different space. So, for example, if you have immunocompromised staff members, and I've certainly had direct experience with working with clinicians like that, who absolutely would be at risk if they are in an unsafe working environment. So that would be a unique circumstance that a practice might use to say, well, we don't find that risk then acceptable in terms of protecting our workforce and perhaps protecting our larger patient cohort. So you may have then a more reasonable position to be more, disciplined and strong in your response in expecting staff to come on board with vaccination. And again, I guess I would say that if a practice is having difficulty deciding where they balance the occupational health and safety or the work health safety issues for their practice with individual staff right to choose how they play in that space, probably your MDOs is a really good call to make to help them or help your practice to arbitrate that fairly and on an equivalent basis, so that you've taken all of the relevant factors into consideration. I would be looking for that further feedback if you're really struggling with the ethical dilemma that sort of sits behind that. As far as the RACGP standards are concerned, I would say what a wonderful example, and document that down no matter when your next accreditation visit is, and actually take it to your practice team. So it's a wonderful issue to actually discuss with the broader practice, to say this is actually a dilemma. There are no real easy answers here, but where do we sit? Where should we sit? What's everybody's opinion on it? And therefore, what's the decision that the practice has made in terms of how they respond to that ethical dilemma? And then document that. So you're kind of covering off a few domains in the one go there. So we did get a bit excited about this particular question, didn't we? I'm really keen to hear from practices. Perhaps pop it into the chat box if these are considerations for your practice, and perhaps also let us know how you've decided to respond to that. Or if you agree that allowing individual staff members to just decide for themselves is a perfectly reasonable approach to take. Linda, have you got any thoughts in that area, or Katrina?
Well, we know it's not mandated, so that's always begin with that. And I just popped in the chat there from ARPA some position guidance for health professionals around roles, I guess responsibilities, but something to think about. But I think I think that it's a discussion that has to happen between the individual and their healthcare professional. So yeah, I think that's where it is at the moment.
Okay, excellent. What else have we got here on the question list? Has there been any talk about the government providing indemnity coverage for nurses administering the COVID vaccines?
So you're covered underneath your own practice if you're in-house, right? APNA, do you want to speak about APNA's insurance that they might have as coverage? Linda Govan, you probably cross that better than any of us.
I'm not working for APNA these days, but my understanding is that the insurance that they provide also, it covers nurses in this instance, definitely. Yeah.
Yeah, and certainly from the practice perspective, if practices undertake practice insurance, so that's separate from the individual clinicians having their own professional indemnity. If the practice has practice cover, it absolutely covers the actions by all its staff. And well, of course, you'd want to ensure that your nurses are actually listed on that policy, or the number of nurses that your practice engages need to be listed under that policy. But that would certainly cover practices as well. What else have we got here? What can we do to ensure that patients who have consented and received first doses have the second dose?
So you can book them in. That's always a good starting point for their second dose. Obviously, we've got the guidance on how many weeks and days between two doses, and obviously being mindful of we're now going to start the flu vax rollout soon, and so that we need to make sure there's 2 weeks between those as well. My mum and dad actually got a text message from their clinic saying that there's vacancies available today for them to have theirs. So you're optimising your online booking service, starting obviously with the age groups as a starting point, and then rolling into your chronic diseases. But my biggest take-home message is book them in and use those reminder and recall systems that are automated versus putting further demand on your reception team, because let's face it, I think the poor receptionists out there, poor practices out there this week that ended up with, this whole host of people calling them just about, I'm due and I'm from another practice and can I book in? And, it's been a bit chaotic, hasn't it? So whatever way we can start to be a bit more structured and have a little bit more control around that. In terms of can you make them? I guess, again, it's about utilising that informed consent process and getting them to understand it's not just one dose. This is your first dose and you need to have the second dose. And we want to be mindful from a business viability perspective as well, Riff, which I'll throw to you to dig deeper into, that the second dose is obviously going to be more beneficial from a practice perspective as well.
Yeah, absolutely. So what Kim's referring to there, of course, is the linking of the additional $10 payment through the practice incentives program, where a practice has delivered both the first and the second dose as well. Or it's not even saying that you've delivered the first and second dose, but you've undertaken the assessment for the first and the second dose. So again, this is a bit of the complexity around the way that the MBS items are actually phrased and what you're actually being paid on. So it's probably a good point to just reflect back on that the actual MBS item numbers are for the assessment and consent processes, with then the actual administration of the COVID vaccination being that last part, which doesn't attract any additional payment. So whether the patient proceeds to that jab in terms of whether they're ready and they have consented is kind of neither here nor there. So it certainly could be that if the first vaccine has been given, you are then presuming that, of course, the patient is going to be consenting to the second vaccine. But if at the second vaccine time it is deemed that the patient is not ready to receive the vaccine because there are complications or there are other health issues that interfere with that readiness to receive the vaccine, then the item number for the second COVAX can still be claimed, and that would trigger that additional $10 payment, even if the injection isn't given as such. So again, it's a bit of a mind spin to kind of contemplate how all of that happens, but definitely desirable for one practice to claim both the number 1 and the number 2 vaccine. And of course, that's related to the provider numbers of the GPs that are within a practice. So it's linked to your practice identification number, which is your PIP number, not the individual GP. So it doesn't matter if practitioner A or B within one practice authorises and ultimately bills for any of those services. It's the practice that they belong to that will sort of capture that additional $10 payment. So that's an interesting consideration in the way that you map that. I think your reminder, as you said, Kim, your reminder recall processes are going to be really important in that. But what we're hearing from practices too is that really you want to be booking in the second vaccine at the time when the first vaccine is being planned. You want to already be doing that from the outset to ensure that there is an expectation that that second vaccine is going to take place, and to kind of minimise the administrative burden on trying to recall patients in a different way. So I think be really clever about it and book patients in one go right from the outset is probably going to be the most effective way to get that happening.
I've probably got about three things from that. So I'm going I think breathe. So what would be really probably a good point here too, Riff, is to talk about that email address that you were talking about, the one you saw in the Practice Managers Network. I think that would be a really nice little piece to add here as well.
Yeah, so this is around some novel approaches to sort of avoid the telephone overload, and I know that this is what practices have been struggling with, especially in the last week or so, with hundreds of phone calls coming through. So one practice that I heard from, and I thought, oh, what a golden nugget! I just absolutely love that. What they had done is they set up a unique email address for their practice, and they might have called it something like COVAX at yourpractice.com.au, and encouraging patients to simply send an email to that email address, and then setting up an automated response so that anybody who emails that email address is going to get an automatic response with all of the information that the practice would like to convey to that patient, including consent forms and the do's and don'ts and the Q&As and the particular booking instructions for the practice. So again, by therefore streamlining that, it's hopefully going to avoid patients from spending too much time trying to seek verbal answers from receptionists who are getting extremely tired of having to give the same information over and over. And obviously you'd want to put that email address, advertise it within your waiting room, let patients know if you need information, email there and it will come to you. Put it onto your website as a splash. The first thing patients see when they come and visit your website is exactly that instruction, or even a click here, which is going to set off that email chain and activity. So yeah, lots of different ways that you can massage that. But I love that suggestion. I thought that was golden.
I've got another thing that I've been seeing a lot of, and I think it's really worth noting in this discussion piece, practices that aren't 1B, that are getting inundated with patients ringing and saying, I need a shared health summary. So booking them in to get your shared health summary versus just printing them off and handing them out. Have you got any other thoughts and commentary on that, Riff?
Yeah, well, gosh, what can you say? I guess if we think about the intent of the way that the COVAX program is being rolled out, then, certainly, going overboard with pre-vaccination assessments and scrutiny, I don't think that was quite on the radar of the federal government when they are developing, these systems. However, we are now dealing with a 1B cohort, which is different to a healthy population. So I think, again, an element of risk management needs to apply to this situation as well. When you're getting patients who are perhaps elderly or complex with chronic conditions, it may be advisable to do some pre-screening of that to ensure that it's all ready to go. We know that kind of scrutiny is not included in the COVID vaccination items. It really only allows for a very short, ready to go, off you go and get vaccinated. But, there have been other suggestions where, you sort of stack a number of appointments before this happens, and I can't say that I'm in favour of that kind of approach. I think that is just quite contrary to the intention of the program. But think about your patient cohort. I think perhaps for the 1B you could be a bit more flexible with that, but as we're going into more general population vaccination rollout, I think you're going to have to pull back on that sort of deep scrutiny of everyone who comes through your doors, because that's certainly not going to happen in the vaccination hubs. And so I think, fair and reasonable. What would your peers consider of the way that you're planning to run it? I think that's always it's the pub test, isn't it? Does it pass the pub test or not? I'm really keen to hear from Katrina and perhaps Linda on what your thoughts might be around that.
Around looking at eligibility, is that what you mean?
Around additional consultations before you decide whether a patient is ready or whether a person is ready to go ahead with that assessment and consent for the COVID vaccination.
I don't think I'm probably the best person to ask. I think what you've said is absolutely appropriate. Yeah.
Okay.
There is a question in the chat, Riwka and Kim, from Donna.
Tell me, what's the question?
It's, are practices getting consent forms and cards to give patients like the government hubs have, or is this another cost the practice has to wear in rolling out the vaccines?
Well, I'll let you speak first, Kim, but I've got some thoughts around that too.
Yeah, well, I've just been seeing lots and lots of discussion in the Practice Managers Network about the cards. Apparently there's some back order on some of the cards. A lot of the online booking systems like Hot Docs, etc., have got consent forms embedded in their online booking service. There is obviously the one that the department, apparently it's quite lengthy, but the main part that I would say is that you want to get informed consent, and that can be verbal or written. The main component is that that person knows that there's 2 doses, what to expect. If they do have an adverse event, that all adverse events are to be reported and how they go about that. So they're the probably critical components, and obviously checking for eligibility. There is a Health Direct eligibility checker as well. And of course, you're going to need to send your patient, if you're not a 1B practice, with some sort of documentation to assist the 1B practice to see that this person is eligible and ready to be vaccinated. What did you also have to add to that, Riff?
Yeah, look, I think, in terms of giving cards for patients who have actually received the vaccine, I would say, you may well be doubling up on workload when that information is, is going to be uploaded to AIR, and patients should have access to their vaccination history through their My Health record as well, and really encouraging the take up of those solutions rather than, creating more paper and more work and more pens on pieces of paper. I just think, use the tools and the systems that are already there.
MyGov as well. If you don't have a My Health record, there's MyGov as well.
Yes.
Yeah.
Yep. So go on.
Sorry, and we chased this up yesterday with the Commonwealth as well, because there is some conflicting information about whether there are hard copies, and the feedback from the government was that it's only online resources. So I understand what Donna's saying, and that if you are going to print it, it is a cost to practices that hasn't been covered really. So again, these are the types of things that we can take back to the Commonwealth in the discussions that we have, the extra burden on practices that we're starting to see. Yeah.
Fantastic. And it looks like there are a few other questions coming through. So I think we've answered that. If a patient has a consultation to discuss whether they should have a COVID vaccination, can it be a telehealth consult? Oh, that's a really good question. My take on it is that the answer to that would be no, because as part of the eligibility criteria for claiming the item, it is that you are ready and able to administer the vaccine if it is appropriate to do so. So clearly that wouldn't be the case if it's a telehealth consult, because the patient wouldn't be with you and you wouldn't actually be able to administer it. So the answer to that would be no, but there may be an opportunity to use a telehealth consult for just a standard consultation type of item, or obviously a telehealth item, to have a conversation in preparation for that. Again, with the caveats that we've just previously discussed in terms of what is the discussion that's taking place. And is that an additional unnecessary consult? Are you going to be drawing the ire of Medicare and perhaps putting the spotlight on yourselves for Medicare audit? And I don't know whether it is or isn't. I'm certainly not trying to scare anyone, but telehealth could definitely be used for that, but not in claiming the COVID item numbers. Okay, does every side effect, for example, headache, sore arm, need to be reported to SafeVic, or is it only those that are not expected or a significant reaction? Kim, that's your domain.
All of them. So unlike what we usually have with FluVax, they want to know everything so they can collect the data. This is such a new kid on the block. They want to see what's out there. So again, you can, the patients themselves can report it. So that could be some part of your process of when you have them waiting for 15 to 30 minutes. But of course, we want to know about absolutely everything. We want to make sure that everything's getting reported as well. Yeah.
Okay. So again, another question has come through, which is kind of similar to what we've already covered. Is there any problem? I think that's doing, not doping, a consent eligibility appointment prior to the vaccine appointment. So I think we've covered that off in terms of, doing that risk assessment. What sort of cohort of patients are you looking for? And where does, where does the pub test come into this? as far as whether you do or you don't. And I think there's a really there's an equal amount of practices that are saying, no, it's absolutely necessary if we're considering we're a health organisation, and ultimately we carry the responsibility to what happens from our premises. Therefore, we need to assure ourselves that we are doing this in a safe and effective manner. Then absolutely the answer would be yes, you would go ahead and do that. And Kim has asked,
I think it's important to also mention that that practices can actually bill it twice if someone comes in and you were going to, put them through the assessment and screening, they're eligible, but they're just not ready. So that doesn't inhibit you as a 1B practice from reprocessing that billing at a later stage when they are ready. So if they come in today, you do all the discussion with them, informed consent's really important. You do the assessment, you do the screening. You can actually claim the first item number because it's not about the actual administration of the vaccine. And then if they decide, no, I'm not up for it, I need to go home and think about it or talk to my family, which is exactly what my mum and dad did. They rang me and said, shall I have it? I'm going, yes, go get it. So for them, then, of course, they can reclaim it on a separate day if they go through that informed consent and mum and dad say, yes, of course, I want to have it, etc. So I think that's really important for practices to know that you're not going to miss out if a patient doesn't actually have that vaccine on that same day.
Good advice. And there is another question here as well. Isn't it a requirement for us to provide that written information to the patient? So where does that sit at in terms of what needs to be documented and written information versus verbal? And I think, specifically around that consent.
Yeah, we need to make sure they know how long that they've got to wait for. We also want them to know that they've got to come back for a second dose. We also want them to know what's common. And even though they're common side effects or adverse reactions or adverse events, we still need them to be reported. I think they're the critical things, just to, again, make sure that they know that although, anaphylaxis may be very small and nominal in this, we need to know about the sore arm, the red patch, obviously temperature change or feeling a little bit fatigued or lethargic. We need all of that to be reported and not to dismiss those symptoms. And I think that's really all you want to hand over as they walk out the door, the number that they can actually then report it to, their next appointment, so that, again, they know not to call the reception desk and say, I've got a sore arm, what do I do? All of those key components. Health.gov site's got a lot of resources on there. They've got video explainers there that you can showcase and put on your social media, on your TVs in your weight bay. They also have lots of these handout resources that, yes, we may mention of, they are downloadable that you can print off yourself, and that is at a cost. But again, I think the key critical things are that you're actually going through this in a considered way, particularly for people who are deaf or maybe illiterate or maybe, a little bit anxious about the whole process.
Great, thanks for that. And there was some clarification from the question asker that it was the question was mostly around the vaccines and the details of the batch. And Kate Graham has very kindly responded to that to say that written information may not be the best way to communicate all information, especially when thinking of different patient cohorts with regard to health literacy and cold communities and the like. So look at what sort of resources you've got available to assist with that, and health pathways, of course, is a key component there as well. So that's great. So yeah, thank you, Kate, for coming in as well and helping out with some of those answers there. What else have we got here on our list? I've
got one that's a little bit interesting, I guess, but really important for the 1B practices particularly. This comes from the 1A rollout, and HCA put out an announcement regarding, obviously, patients who have maybe been in respite in an aged care facility and received the first dose of Pfizer. they need to go back to the same facility and have their second dose of Pfizer at that facility, because of course the immunisations aren't interchangeable, and nor have they catered for people going to different sites. So they can't go obviously to a hospital site and get their second dose of Pfizer. Just things to be mindful of. And also there's been a lot of discussion again around anaphylaxis because of the aged care facility, and the department actually made mention of this the other day, that, you know, GP practices are well structured to receive patients who have had anaphylaxis or a severe reaction. But again, informed consent is the way to go here, so that they know, you know, that they've got to wait 30 minutes and what to look for, etc. And you guys obviously will need to have all of the systems in place to deal with anaphylaxis, which no doubt you will have.
Fantastic. And I've just brought Kate back into the conversation here, and hoping you can join us for the conversation. Kate, are you able to?
Yeah, I am here, but it says that my video has been stopped by the host. So
okay. Well, while you have a bit of a chat, let me have a look and see if I can remediate that for you.
That's all right. I'm happy not to be seen, but I think we're always happy, and I'm happy from my role as sort of COVID clinical coordinator, clinical advisor with the PHN, to answer any questions that practices may have. I think some of the work that I've been doing has been really linking in with and having those close links with the medical advisory team and the primary care team at the Federal Department of Health and the State Department of Health. So like some of the issues that we've been seeing have been really easy to remedy or really easy to get clarification or answers. And we've actually been able to influence what they're doing. So, for example, like they hadn't flagged up the Easy Read disability resources until somebody mentioned that on one of our echoes, and we were able to take that to the department, and they thought that that was a great idea. So they got them out within a week. Other things that we've been advocating for is sort of questions from practice managers about, you know, funeral directors not being included and where are they going to fit in, and we're able to get clarification on those issues. So definitely keep sending questions in. Health Pathways is just a really useful resource because there's so much information that isn't state and isn't federal, isn't covered by either of them, and we're kind of that place in between, and we're being really promoted by the Department of Health federally and increasingly so by the State Department as well, just to be that fill-in space for general practice where some of the information from the federal government doesn't meet our state requirements. And so we wanted to be able to provide that translation piece for everyone. So we've got the preparing for COVID vaccination, which really is that practice management side of things. But more importantly, the resource page has it really nicely arranged into sort of categories and things. So it's easy to find what's state information, what's federal information, because neither the federal or the state departments really have an easy way to find a lot of the resources out there. So keep looking on our site as well. And hopefully, if we can't find what you need, we'll get onto it.
Fantastic, Kate. Thanks for that. You're able to turn your camera on now, so feel free to come and show up. Oh, there you are. It's lovely to have a full house now. That's tremendous. Thanks for that. Another comment has come through from Jennifer. I think it would be fantastic for the Commonwealth to provide a one-pager re-notifying adverse events, what to look for, what's common, and the number to ring with every box of vaccines supplied. I also think it would be fantastic if the Commonwealth provided stickers we could give to people to wear stating I've had the COVID vaccine once given, which would be a way of promoting the vaccine, and T-shirts for staff to wear stating, yes, I am COVID vaccinated. So much to talk about this in general practice, and staff are already becoming exhausted repeating the same message, and our practice hasn't even started administering yet. So doesn't that just show, you know, the pressure and the unrelenting nature of the space that we're now inhabiting?
So I think one of the things
Absolutely.
that I know that the State Health Department is, I was just going to say one of the things that the State Health Department is working on is having one of those forms, because the federal government isn't really sort of, their forms are a bit too complex for the after vaccinations. So that's one of the key areas. And one of the other things that the federal government's working on that'll be great for practices to know about when it's released, which will hopefully be being recorded over the weekend, is a vaccination video which goes through sort of those pre-consent questions that you can have playing in the waiting room just before you sort of take people through so that all their questions are already there. They know what to tell people about. So that should also make life easier.
And I was just going to add that, you know, I think that's a really critical thing that we need to be mindful of. There are humans in general practice that are actually going to be having to do the same long haul. It's not going to be very quick in terms of delivery. This is not going to be over anytime soon in terms of a vaccination program, because we've still got flu vax as well. So making sure we're looking and monitoring for burnout, making sure that we're having regular huddles to check in with team members to find out everyone's up to date with what's required, checking in with people's energy levels and seeing how they are coping, and just doing some little fun things. I've seen, you know, in the Practice Managers Network, one practice manager had bought the team some socks with, you know, some little bugs and needles on them, and just some little simple things just to keep morale up, and making sure that we're pacing at a rate that's sustainable long term, you know, making sure that we've got additional workforce if required, etc., so it doesn't fall on everyone's shoulders. I was telling the team earlier prior to this workshop that I was driving through Coffs Harbour on Friday, and visibility was very nominal, as you can imagine, with the floods that were up there. And one of the practice managers had just had all her staff been sent home because the kids were actually getting evacuated from school. So she had no staff, the electricity went out, and she had the DHL delivery man deliver 1,200 vaccinations to her. And she said, I can't take them, I have no power. And he said, well, you can't not take them. I haven't been given directions on not taking them. So she ended up pulling her socks up and taking them to somewhere else to get stored in the meantime, and started to think about, you know, what other support structures could she lean on. And thankfully there is the Practice Managers Network where you can go and say, I've just had this moment, this is my day, and a lot of people can, you know, rally around you and provide that support and that sage advice so that you can actually get through your day with knowing that, you know, we're all in this together, and, you know, we're all there to support each other throughout the process.
Yeah, and as Kate's just popped into the chat box as well, thinking about rotating staff to ensure that you don't have just, you know, one staff member or a very small number doing the same repetitive activity, you know, day in, day out. That's absolutely true. I guess what I'm thinking of in this space as well is that as much as practices were, you know, really disappointed with how many vaccines they were going to be allocated in the first round, and kind of going, we were planning on, you know, the big rollout and we've got next to nothing, is to really use that then as a time to consolidate your processes and really test your workflows and tweak it. So use that sort of PDSA, SMART goal type of methodology to really work out, you know, how is your workflow going to hum, and how can you really refine that so that when you will get more vaccines, and that's coming soon now that CSL is starting to roll out the vaccine production out of their Melbourne manufacturing plant, practices are going to be seeing a lot more stock arriving shortly. So then you can ramp up those activities to what you had imagined in the first place as well.
And Riwka, did you want to add about not hoarding stock as well, the importance of that? How's that going to impact practices?
Yeah, absolutely. So, you know, there were practices who sort of had envisaged that as stock was arriving, that a dose for any patient coming in would be sort of garnished for the second vaccine at that time. And it's been made very clear that that is absolutely not the way that the workflow can take place, because you're simply unable to order new vaccine stock unless you've used up what you've been allocated. So you can't be hoarding stock. There are very strict sort of stock control mechanisms in place to stop you from doing that. So please just keep vaccinating and trust that you will receive stock for the second vaccines for the patients after that 12-week period. And I know there was a question there too around that 12-week period, Kim, in in terms of how close to the 12 weeks do we need to sit? How much earlier can we go, or how much later can we go? What's that sort of reference range looking like?
So in the mandatory training, it was saying 4 weeks, but you'd have to have exceptional circumstances as the minimum. And then maximum, I'm not sure. I'm going to throw it to Kate to see if there is a maximum.
There's really no maximum in terms of patient safety and that kind of thing, but the recommended maximum is that 12-week period at the moment, because we know that your immunity is better at that 12 weeks rather than the 4 weeks. However, what all the reporting agencies want you to do at the moment is, if you're going over that 12 weeks, it's got to be reported as an adverse event. And that's just so that they can follow it up. So that's one of the requirements, that if it's going significantly over, or if you had something that was significantly under, you've just got to report that. But, you know, the reality is we're going to probably try and get it within that week. And the best way is sort of in terms of your planning, and that planning for that second dose and thinking about how much you'll need at that point in time, is to actually book those patients in as they're coming in for dose 1. So that's kind of their leaving present as they go away. Here's your dose 2 appointment, so that when you're trying to plan, okay, how many vaccines am I going to need next week? You've got those appointments already booked for those patients. You know that they're within that right time frame, and you're not going to have to spend all your time making adverse event notifications.
So, Kate, in reference to a live one, I had a lady who started in a job, and she's from the UK. She had her first dose in the UK, and then she's been over here in quarantine in Western Australia for 2 weeks. And she said to me, now I've actually, I'm outside the range. She said, and I think I have to start again. What's your advice there?
There's definitely no requirement at this point in time to start again with any vaccine courses or doses. Even if somebody has had for some reason, you know, a Pfizer vaccine, and they've been advised not to have a Pfizer vaccine, and their second dose is an AstraZeneca, they don't restart the course. Nobody restarts a course. You just get your 2 doses. And at this point in time, that's where we're sitting at. That doesn't mean that in the future we may not have booster doses, but we're pretty happy with where the immunity sits, even if there's that variation. And, you know, you think about it like some of the other vaccinations that we get with our sort of annual flu vaccinations, your immunity is sort of boosted each time, or even with Hep B, we know that your Hep B, you can space that out, you can have it closely. There's lots of variation in where vaccine doses are given, but we've just got those absolute requirements at the moment because everything is so new and they want to be able to track what's happening. But don't worry if it's outside that range. It just means we put in that notification. It's perfectly safe for the patient, and they'll still be making that immune response.
Beautiful.
So I think one of the key messages is that practices simply need to stay abreast of the new information that comes out at a pretty rapid rate, that you've got to keep your eye on those government websites, because that's where that information will come from, and through PHNs, so that, you know, you're not too far behind the times, because, you know, the instructions, they do change just so very rapidly, don't they? And we just have to kind of be ready to be nimble and to change the way we've thought about what we're doing to, well, what do we know now and what does that mean for us? So it's that nimbleness around it, I guess.
And I think making sure that you're subscribing to all those notifications. So you can subscribe to the Federal Department of Health newsletter. We've got a link to subscribe in Health Pathways in the information page, to subscribe to the State Department of Health newsletter on vaccines, which is only a relatively new thing that's available for primary care. And really, they're kind of the places where I get a lot of my information from. But also on all of the Health Pathways, if we've changed something or we need to flag something that's really important for people, we put that in a big orange note at the top. So kind of like think of that as your post-it note of this is what you can't miss. Because sometimes, like last week on Friday, we got the information sent out about allergies that wasn't correct. We've flagged that immediately, changed it, sort of got the Department of Health to change their thing, but because it wasn't sent out to everyone, we flagged that at the top of Health Pathways. And we've also flagged the fact that on the eligibility checker at the moment, that the eligibility checker will still let in 16-year-olds if they've got a medical condition. So just double check everyone's age before giving vaccines.
Excellent. We've probably got just a couple of last questions before we wrap up. And Kate, this may be really relevant for you. What do we tell patients when they raise concerns about the vaccine, particularly the clotting problem?
That has been everywhere in the media, and I think this is a really different space to where we usually work, which is where people get medical information from medical sources. Instead, we're getting a whole lot of information from the media without that backup of actual sort of science behind it. And a lot of other nations have really different procedures and different political sort of motivations for why they shut things down really quickly. So in terms of the vaccine and clotting risk, we've got some really good statements up from ATAGI, from the TGA, all about the fact that we're really comfortable with the fact that there is no overall risk of clotting disorders. And it's the same for sort of, they've looked at things when there's been reports of adverse events in the elderly. They've looked at all of that. So they keep refreshing that information. We've got some good links as well for misinformation. So there's a website or a page from the Department of Health called Is It True? NCIRS also gives some information out, and sort of being able to provide those patients with that information to those really common questions that they'll have is so important.
Fantastic. Thanks, Kate. And just one final question before we get into our song lyrics, which we've been just itching to do as well. So from Adriana, any recommendations on whether separate nursing staff are required to vaccinate and then monitor patients for the 15 minutes, or is sitting in reception waiting area post-vaccination sufficient monitoring? Kim?
Well, again, it's going to come down to your workforce capacity and whether or not your reception staff have done their first aid training, their basic life support. Are they aware what signs and symptoms? Have you got adequate space for them to actually monitor people without them being distracted? There's lots of considerations there. You want to make sure that the person that is going to be their first aid officer is actually eyeballing them and checking on them and making sure that, you know, people are safe, and that, again, you've got somewhere to repose someone if there's a vasovagal or, you know, someone actually does have an event, that there is a confidential and private space to deal with them and manage them. Kate, have you got anything else you want to add to that?
No, I think that that's the main thing. It's just making sure that you've really got that visual, that there is somebody who is adequately trained to be able to see all the patients, and thinking about that as you're planning a setup for the room. It's just really, where are people sitting? Are there any areas where you can't see people? Because the last thing you want is somebody slumped over in their chair and not being able to be seen.
And the toilet, don't forget the toilet. The toilet's always a common one. Are they eyeballing it to see that you know, toilet hasn't had that engaged sign up for, you know, a long time, and we've got someone passed out in there? So just, and
if you've really got that waiting area set up, you'll know when somebody's standing up to go in there, and hopefully not taking too long.
Exactly. So gosh, hasn't this hour just flown by yet again? I think we could sit here for probably another 2 and just keep chatting along, but today's session is nearly done, and as you'll recall on the registration form, we just wanted to add in a little bit of joy and fun to just kind of move away from the seriousness of what we're doing all day every day. And so we asked you to supply your favorite misquoted song lyrics, and Katrina from West Vic has collated all of that information for us. So Katrina, what did our registrants come up with?
Well, I'll share my screen. I put them into a presentation. It was really quite funny seeing these come through. So I'll just share my screen. We thought this might be a great way for this to finish off our session today. That should be sharing now. And just while that loads, I'd just like to thank Kim and Riwka for helping us out today. Are you seeing my presentation now?
Yeah, absolutely.
Yes. Okay. So we've called ourselves the West Vic Whalers. Thanks to everyone who put their presentation, put all their misheard lyrics through for us. So this one here was a favourite. I guess it rains down in Africa. So I think we can all guess that's supposed to be I Bless the Rains Down in Africa by Toto. So I think we can thank Dee for that one. We saw this a couple of times. cheap wine and a three-legged goat. I hadn't heard that one before, but we've got a little bit of cold chisel for us there. Should be our 3-day growth.
Oh, Katrina, I thought you were going to be singing them as well. That's what I was
Well, I think we've kind of run out of time. I can sing a couple if you like. She Don't Like That Canada Highway. So that was Australian Crawl. She Don't Like That Kind of Behaviour. So this one was an interesting one, Like a Virgin, touched for the 31st time. So Madonna was most definitely misheard there. And this one was actually mine. Every time you go away, you take a piece of meat with you. So it's supposed to be you take a piece of me with you. And I can see clearly now the rain has gone. So I can see clearly now the rain has gone makes a bit more sense. And then we got this couple of times, kicking your cat all over the place, and I couldn't resist a little bit of the cat meme here. Kicking your can all over the place. I'm sure Queen would get a bit of a kick out of that too. Alex the Seal, that was an interesting one. It was the Go-Go's, Our Lips Are Sealed. And Dress You Up in Milo. This one was a bit intriguing, but we had Madonna again with this one. Dress You Up in My Love. That was an interesting one. And I think we've all heard this one. We built this city on sausage rolls instead of we built this city on rock and roll. So sausage rolls gets in a couple of times here. We've also got It's a Long Way to the Shop if you want a sausage roll. Bit of acadacca for everyone. And I think that's it.
Look, absolutely magnificent. It's certainly given us a bit of joy and a bit of a laugh, and I hope it's been a little bit of light relief for our audience today as well. So I'll hand it back to you, Katrina and Linda, to wrap up today's session.
Yeah, thank you. A big thank you to Riwka and Kim for your insights today, and for everybody with your questions coming from the audience, and Kate as well. Really appreciate your input. Just quickly, just wanted to let you know that the PHN has sponsored an additional 60 nurses to do the nurse immuniser course through Benchmark. So that's an 80 in total. So that will help get that expertise out there in the sector. So that's a really good piece of news. The next session for this will be at the end of May in our primary care refresher. I believe bookings aren't open yet.
Not quite.
Okay,
almost.
Yeah, but well, if you want to hear Riwka and Kim again, and who doesn't, let's book in for that in a couple of months. So again, thank you for your time today. We've just run over by 1 minute, and so have a good rest of the day, and yeah, good luck with the rollout. Thank you.
Thanks
everyone.
Thanks, everyone.
Have a great day.
Bye.
Thank you.